Resilience is often used in global discussions about how health systems can respond to unforeseen crises, such as the Ebola epidemic in West Africa, natural disasters, or even economic crises. But many health systems, especially those in low and middle-income countries, face multiple routine challenges and strains that demand resilience every day to ensure a continuous delivery of health services. District health managers and those actors who oversee the running of health centers and hospitals or coordinate networks of primary health services are responsible for overcoming many of these challenges. On any one day, they might have to deal with staff absences, tensions among staff, new policies, reporting demands, payment delays, multiple meetings, drug stockouts, or patient complaints. In countries that have recently devolved health services to provincial or local levels, such as South Africa and Kenya, additional challenges arise from uncertainty around roles, responsibilities, and new managerial directives. These challenges are not always acute external shocks. Instead, many are chronic stresses that are internal to the health system. Many become infused in the routine organizational life of health systems. The stresses occur at the same time in the same system, impacting on the same set of people. Change, uncertainty, and surprise are part of the everyday life of health workers. The situation demands everyday resilience. But how do those working in district health systems respond to these routine challenges? This is one of the questions that we as researchers have examined in Kenya and South Africa, working alongside health managers and frontline workers to better understand the health system from within. Together, we've identified a range of strategies used to deliver health services in the face of constant strain. These strategies fall into three groups: absorptive strategies, in which individuals exercise their own agency to solve problems, often with minimal effects on the wider health system; adaptive strategies, which lead to new ways of working being discovered, for example, by collaborating with others; and transformative strategies, which result in new processes or routines that actually outlast the original challenge and change ways of working in the future. An example to demonstrate these strategies is the challenge of implementing a measles immunization campaign within the community following an outbreak. Here, an absorptive strategy might involve staff working longer hours to reach immunization targets. An adaptive strategy might entail drawing additional staff from other activities to work on the campaign. A transformative strategy might be for facilities to hold yearly catch-up sessions to reduce immunization backlogs and the need for large-scale campaigns in the future. We found that, in practice, while some strategies nurtured everyday resilience, enabling health systems to emerge from challenges strengthened and more resourceful, others did not, and sometimes led to undesirable and unsustainable practices. We call this maladaptive emergence. What was it that enabled managers and frontline workers to adopt positive strategies that nurtured everyday resilience? The evidence points to the need for three interacting sets of organizational capacities. The first is cognitive capacity. Cognitive capacity is about sense-making and include being able to make meaning of situations, acting creatively, or being decisive. And these capacities underpin the potential for problem-solving and action. For example, facility managers recognizing the need to motivate staff to go the extra mile in campaign activities by persuading them of their value for the community. The second is behavioral capacity. Behavioral capacities are about agency. It's about what people do to respond strategically to stress, such as establishing the annual practice of immunization catch-up sessions, avoiding the need for campaign activities. The third is contextual capacity. Contextual capacities are about the resources facilities draw on to facilitate resilience. These include hard and soft resources such as social networks. These capacities support organizations to act quickly in uncertain conditions. For example, enabling quick managerial action in response to a measles outbreak. Everyday resilience, then, is nurtured by developing organizational capacities that enable actors to adjust to and learn from routine challenges and to preserve or even improve health system functioning. Given these ideas, what strategies and capacities did we find important for everyday resilience? Our experience suggests that everyday resilience arises, in particular, from the type of leadership offered by multiple managers at different positions and levels within the health system. Such leadership is one that empowers other people to solve problems and make decisions. Relationships and social networks within the health system are also important to everyday resilience, as well as relationships within wider communities, as they can provide access to a range of resources needed to support transformed ways of working. Finally, material resources and organizational structural resources are needed, but are not sufficient by themselves to sustain everyday resilience of health systems. These findings have important implications for policy and practice. Firstly, governments and donors must pay greater attention to strengthening leadership practices. Leadership that reframes challenges to support problem solving, that embodies respect and empowers others, particularly frontline managers and staff, that enables learning and innovation, and that draws on and catalyzes social networks and relationships across, within, and outside the health system. This requires new approaches to leadership development, especially those that involve learning through doing. Finally, new forms of collaboration between health managers and researchers should be supported. As we have shown, it can nurture an understanding of the complexity and importance of health system resilience and how to build it.